Absolutely. Yeah, thanks guys for making the time to come on over today. So like you see, we're going to talk about some of the stroke basics and what changes we have seen with EMS triage, some of the field assessment, things like that. I'm going to go over some of the basic educational objectives, just increasing awareness of the different stroke presentation. We all know the speech difficulty, arm weakness, things like that, but what are some of the other atypical stroke presentation? What are some of the current standards of stroke treatment? Discuss the stroke types, anterior circulation, posterior circulation. I think we've all heard about those things. What do they really mean from an anatomical perspective? Evaluate the importance of examining the patient, practical application of stroke scoring systems. I mean, the big topic of discussion today is that fast ED. How is fast ED going to help us triage these patients, get them to the right place, and how it helps in some of the preemptive planning before these patients hit the ED door or the actual hospital itself, and become familiar with some of the current stroke treatment itself. A lot of these things which you know, but I think it's a good refresher for people who have been doing this for a long time, and definitely educational for some of the newer folks. So what are the two types of strokes? We're going to go into some of the basics of the anatomy itself and kind of walk our way through the important anatomy. What are some of the findings? Walk through fast ED process. Jen has agreed to volunteer for kind of a live demonstration. So we'll give her a stroke somewhere about 30 minutes from now, and then walk through some case scenarios basically. So anyway, going back. So ischemic stroke, hemorrhagic stroke, all of you guys know this. Ischemic is the more prevalent one. I think in our community it's about 87% is ischemic stroke, about 13% is hemorrhagic stroke. Now again, hemorrhagic stroke, different kinds, right? We see the typical hypertensive, blood pressure was 200 uncontrolled, missed my blood pressure medication, bleeding in the brain. That's probably the most commonest. We do see these aneurysmal ruptures. That's the most devastating. And we see everything in between from, hey, doc, I had a tumor 5 years ago and we were watching it. Now that bled, hemorrhagic stroke. Patient is on Coumadin for atrial fibrillation, fell, subdural, hemorrhagic stroke. So that is about 13% of our community's stroke patients. 87% is ischemic. Nationally, about 800,000 strokes. That's why we're all, we dedicate so much time to stroke and stroke care and understanding what stroke is. Every 40 seconds, there's somebody who's having some kind of a stroke. It may be something very trivial as a small TIA to somebody with devastating large strokes or hemorrhagic stroke. So when we look at what we call the stroke market itself and focusing on the endovascular treatment, I think today's focus, is sort of that fast ED score. And why did we even think about or come to that fast ED was how we are going to treat endovascular moving forwards, endovascular eligible stroke patients moving forwards. So if we look at that 800,000 estimated strokes, about 640,000 are not eligible for revascularization therapy. That's that green box where it could be hemorrhage, it could be TIA, time window, they try to sleep it off, 2 days later got worse, now they're outside of every time window, or for various other medical reasons, they could not get therapy. But this is where our focus is, that 278,000, close to 300,000 patients that have fairly high NIH stroke scale and can benefit from endovascular therapy. But right now, nationally, we see only 1 to 7% currently receiving endovascular. In our community, we are probably on the lower end of that, somewhere between 2 to 3%, right, Christy? When we looked at it, I think around 2.5% endovascular utilization. So a lot of still room for growth, just even within the national average, but really we want to get there, right? This is where about easily 30-35% of all strokes will be eligible if they are within time, triaged the right way and come to the right place, eligible for endovascular therapy. So, stroke, the way we see stroke has evolved over time. Just like cardiac care, and I always use this example. 50 years ago, chest pain was chest pain, right? How bad is this chest pain? Do we give just 1 milligram of morphine, or do we need 10 milligrams of morphine? That has evolved over the last 50 years to say, is this NSTEMI, STEMI, unstable angina? Is it just angina, or this is just mild chest pain, acute coronary syndrome? Same way, I think stroke, the way we see stroke, has evolved in the last 5-7 years. This whole concept of large vessel, small vessel, and this whole topic, this talk is all about why large vessel, small vessels is important, but that's something that's changed the way we see stroke. And large vessel, to give an example, is like the STEMI of strokes, right? When there is chest pain, STEMI is one basket, everything else is the other basket. STEMI needs that fast care, acute care, highest level of care. Same way with large vessel strokes, right? When we say large vessel stroke, that's the one that's fast, most devastating, needs the highest level of care. Maybe just TPA is not enough. So think of large vessel as the STEMI. So now what is considered large vessel, right? So when we look at the anatomy, and I have some more anatomy slides, and please feel free to interrupt anytime. The internal carotid artery, the basilar artery, which is in the back of the brain, middle cerebral artery. I also include the anterior cerebral artery right there. So ACA, MCA, ICA, basilar artery. Any of these four are considered large vessel strokes. And we will talk about how we identify large vessel strokes. But the reason they're important is because of the mortality rates. When we look at the table on the bottom left corner, we see ICA strokes, 1 in 2 patients are dead. MCA stroke, 1 in 3 are dead. Basilar, almost everyone dies if they're not revascularized. So that's very important when we have clots in the larger locations compared to something here, right? These are the lacunar strokes, the small strokes, which most often, even with treatment or not, they are recovering quite well. They do go home eventually, maybe a short stint in rehab. Many go home directly from hospital and back to almost normal lifestyle. These bigger strokes are the ones where rehab and recovery is a far story. Half of them, or 90%, don't even survive. So I think that's where we say the highest level of care has to start at second 0, in fact. Now when we look at the CAT scan per se, so this is a patient on the left is somebody who has had hemorrhagic stroke. This is the bleeding in the left side of the brain. This is somebody who has had a stroke, ischemic stroke, no bleeding, looks normal. So we never know on the field how these patients are going to really present. And like the caption says, both of these patients can look the same clinically. To somebody on the field, there's no way to tell, is this hemorrhagic, is this ischemic, is this because of hypotension? And the only way we know is on CT scans. And this is something that's most important, and I think a lot of our treating teams have a difficulty understanding sometimes, is that the most common CT finding in acute ischemic stroke is a normal CT, and that's what we want. Many times we get asked questions saying, hey, how is this a stroke patient? CT scan is normal. That's because I say it's nature of the beast, in the sense that stroke to show up on CT takes about 12 hours. The earliest sign shows up after 12 hours. 24 hours is when we really see stroke symptoms on the CT scan. For me, as an interventionalist, I want to see normal CT, right? Because if stroke is already formed, what are we trying to save? Right? There's nothing left to save. So if the EMS brings me a patient that has normal CT, I'm saying, hey, this is the best case scenario. I have all of the brain tissue to save, to survive, to salvage before it starts showing stroke signs. So I do want to see a normal CT. That is definitely something preferable. That's what we want to see. When there's an abnormal CT, time is already missed. Yeah.
You're saying they can show signs of a stroke but still have a normal CT?
95% of the time. And See, when they show stroke signs and CT scan changes, we've already missed the boat, right? The idea is, we always hear this word mismatch quite often, right? And when we use that term mismatch, it exactly means this. What is that clinical radiological mismatch? So if there is no mismatch, meaning clinically they're looking bad and CT looks bad, then stroke is completed. If there's a mismatch, clinically NIH stroke scale 23, but CT scan normal, that's a clear mismatch. We want to take them to the lab, right? So that's what we want to see, mismatch always. Normal CT is always good. So why did we say time is brain? That's because of the study from UCLA, where we commonly quote the second number. 1 minute of ischemia or stroke leads to almost 2 million neurons lost. So this was basic science research that came out of University of California, Los Angeles. And this is where we have been saying time is brain, time is brain. So with every 1 minute lost, we are losing 2 million neurons, right? So some basics of the anatomy, physiology of stroke itself. So what are some of the signs and symptoms of stroke? Can vary depending on the part of the brain. That's kind of the take-home message. And that's why we have so many stroke mimics and so many things that don't present as true stroke but are stroke, right? We have, and I was just talking to this about the varied presentation to our hospitalist teams. We have about 10% of all strokes nationally that are mimics that we still have to treat aggressively. And about 10% of all real strokes don't present like strokes. They may be, hey doc, I'm having some dizziness, some imbalance. We're thinking, hey, this is ear infection. They're coughing, bringing up phlegm. The primary care physician thinks, hey, this is most likely upper respiratory tract infection, maybe some vertigo from ear infection, but it's actually a posterior circulation stroke. So there are these outliers on both sides. There are these complex migraine seizures that may present like stroke, and there are other symptoms that don't typically trigger that stroke diagnosis but are actually really stroke. So I think we have to be very careful in understanding. And for me, I'm biased in the sense that any dysfunction in the brain, I always say, is this a stroke? And many times it is true. And I think because of all the diagnoses, stroke is the only one that is time sensitive. Seizures are not time sensitive, migraines are not time sensitive, infections may not be as time sensitive as stroke. Only because stroke is the only diagnosis which is time sensitive, we definitely have to rule that out first, right? So if you're unsure, just say, hey, is this a stroke? Possibly give the benefit of doubt, say this is a stroke, so that way we are within those time windows. If we say this is a seizure and it turns out to be a stroke, we have already missed many of those time windows. So that's kind of the trick that I use, and when we train residents and fellows, I tell them this is kind of the stroke gear is a little different. You're always saying it's stroke until otherwise proven, right? And then that way it gets you going faster, gets you within those time windows. Later on, if it's diagnosed as not a stroke, it's fine. You're still meeting those time goals. So what are some of the signs and symptoms? So we have numbness, weakness of the face, arm, leg, usually one side of the body. We all know this. This is, I think, something relatively important to emphasize. Usually when we see bilateral, both arms, both legs involved, the concern for stroke is less. It's not never, but less likely that it's involving stroke of one side of the body or one side of the brain. So that's something important to know. And in some ways, I think it's not going to eliminate the diagnosis of stroke, but in some ways forces you to think about other diagnoses. So there's a patient feeling drowsy, may have some problems with speech, but is weak on both legs. This is a very common scenario. Then we say, yes, is this a stroke? Like I said, always say yes. And then what is the second possibility? We had this presentation that said usually weakness is on one side of the body, but now both legs are weak. What else could it be? Is this maybe infection? Is this maybe dehydration? Is this something connected to medication that the patient is drowsy, slurred speech, and overall generally weak? So I think it should just force you to think of additional diagnoses, not eliminate the diagnosis of stroke. But keep in mind, usually stroke is one side of the body. Difficulty speaking, understanding, we all know that. Blurred vision, trouble seeing in one or both eyes, again, very common symptom. Dizziness, confusion, loss of balance, coordination, that's the tricky one, where it typically doesn't factor into some of our commonly used stroke scales, where when we do the United Stroke Scale, we don't necessarily check for dizziness, confusion, but always know posterior circulation, and we'll talk about what posterior circulation is. Posterior circulation stroke will present with dizziness, confusion, balance, coordination. And then extremely severe headaches with no known cause. Not a very common presentation, but something to keep in mind. Typically represents dissection. When you have pain with stroke-like symptoms, that's dissection. No different from aortic dissection, right? Chest pain with low blood pressure, cardiogenic shock. Same way, carotid or vertebral dissection, you have pain with, instead of low blood pressure, you have low neurological function, which is stroke. So that is something important to keep in mind. So let's see, I think if we bring up all of these. Okay, good. So some of the, the anatomical localization, so to speak. When we talk about the frontal lobe, we have a lot of the motor function related to the frontal lobe. So we have voluntary movements such as lifting arms, legs that may be affected, ability to focus, ability to speak. That's the Broca's area where speech is. Emotional, social control. This is not something we may see acutely. Temporal lobe, memory, understanding speech. When we say sensory aphasia or fluent aphasia, that's the region in the temporal lobe, Wernicke's aphasia, where a lot of the understanding comprehension is lost, but they're talking fluently, but it's all nonsensical speech. So that is in the temporal lobe. Then we have the brainstem, again, very important. This is the basilar artery stroke we were talking about, where 90% of the patients may die if untreated. This is all the vital functions. Breathing center is here, wakefulness center is here, control of all eye function is in the brainstem, so it's very important, supplied by the basilar artery. Then we have the cerebellum, which is all balance, coordination, vision coordination, dizziness. The nausea centers are in that cerebellum. When we talk about the occipital lobe, primarily the vision is where we see. So if there is a patient who is unable to see half side of their visual field or having difficulty with vision, focusing vision, bumping into things, then we know it's a occipital lobe posterior circulation. Good, thank you. Yeah. Then we have parietal lobe. This is where we say awareness of the body parts, hand-eye coordination, naming objects, things like that. And some of the fast ED concepts where we say disregard or neglect, which is the D of the ED, comes from that parietal lobe, where awareness of the body parts. So when we lose that awareness, that's when there is neglect. Any questions so far? Or? Good? Okay. So the vascular anatomy, I think this is very important. We always, I always say stroke follows the blood vessel. So if the symptoms cannot be explained by how the blood vessel is in the brain, you have to look somewhere else. We're knocking on the wrong door. It's probably not stroke. So stroke always follows the vascular anatomy. If there is no blood vessel to get blocked, then there cannot be stroke in that area. So knowing the anatomy kind of helps us define how strokes can present and what symptoms they can cause. The basic, I guess, three big blood vessels coming out of the aortic arch. We have the brachiocephalic, left common carotid, left subclavian, and then we have the carotid artery on the right side coming off of the brachiocephalic, left common carotid artery coming directly from the arch. The carotids on either side divide into the internal, external. That division is right around that C5 mark. That's a common place for stenosis. When we say carotid endarterectomy, carotid stenting, that's 99% of all procedures are done at that level, at the bifurcation. we have the internal carotid artery going up, becomes the MCA, calmness cause or calmness location for stroke. About 60-70% of all strokes are in the MCA. Then there is the other smaller branch, which is the ACA. So calmness location, we said MCA, second calmness is internal carotid artery. And then we have the posterior circulation where vertebral arteries on both sides join to become the basilar. This is the third calmness location for clots and strokes. Basilar then becomes posterior cerebral artery. This is what supplies the occipital lobe vision, right? So when patients have visual field loss, we know it is posterior cerebral artery or basilar artery strokes. So this is a good slide showing anterior versus posterior circulation. So anything anterior technically is anterior. How anterior is it? Anything in front of the basilar artery. So that's the basilar artery. Anything in front of the basilar, including carotid, middle, anterior cerebral, anterior communicating artery, posterior communicating arteries, all of that is anterior circulation. This is the calmness location for strokes. We said MCA is number 1. This is number 2. This comprises about 70 to 80% of all strokes. MCA is about 55-60%. Another 15 to 20% is ICA. Remaining is the basilar and the vertebral arteries. So that's why when you guys see patients on the field, most of them have speech abnormality, weakness. They may have leg weakness, arm weakness, facial droop. That's all coming from MCA, ICA occlusions. So again, we talk about circle of Willis. This is nature's way of providing some layer of protection to the brain itself, where these connections between the anterior and posterior circulation create redundant channels. So if there is an occlusion, say in one of the ICAs here, there's blood flowing from the other side into the opposite side to restore that blood flow. So this is an important slide, and this is kind of the physiological basis of how fast ED came about. So when we talk about some of the anterior stroke symptoms, we say think cortical or subcortical. What does that mean? And that's where we talk about why we chose fast ED and why is it only FAST ED and not other signs or symptoms. So when there is large vessel occlusion, all large vessel occlusions are associated with cortical signs because they are large enough to cause stroke in the majority of the brain tissue, the cortical portions of the brain tissue. The small vessel occlusions are the ones, or the lacunar strokes are the ones that cause more subcortical. So when we look at what cortical functions are, it involves the higher functions of the brain, involves gray matter, involved with large vessel occlusion. And primarily, is the subcortical strokes affects the smaller fibers with small vessel occlusion. And when we talk about the symptoms, there are only 4 things that we need to know for cortical strokes. Language, we always say, assess the speech, that's the S in the fast ED. Gaze, so people normally look straight, eyes track to both sides. Gaze is abnormal when patient prefers to look only to one side. Then we have the visual fields, peripheral vision. Neglect, people normally pay attention to both sides. Neglect is present when a patient completely or partially ignores things on one side, right? That's the basic definition of neglect. So these 4, language, gaze, visual field, neglect, are the primary 4 cortical function. And why we need to know those is dysfunction in any of these 4 means cortical dysfunction means large vessel occlusion, right? So we are kind of working in reverse, and this is all because unlike STEMI, we don't have ST elevation, we don't have troponins, we don't have any, ways to tell, hey, this is a large vessel stroke versus no. So we have to go with clinical exam. And we know from science that for the cortex to be involved, large vessel has to be occluded. And if that is occluded and cortex is involved, these are the 4 symptoms that we have: language, gaze, vision, neglect. And those are basically the components of fast ED. Subcortical symptoms could be weakness, sometimes not completely localized, numbness, dysarthria. So these are some of the symptoms that we see. Again, this is majority probably of your patients that come in where they're saying, hey doc, mild dysarthria, I was slurring my speech, lasted 30 seconds. By the time EMS brought me to the ER, it had disappeared, and now I feel completely normal, maybe just a little tired. And these are still majority of our patients, but are related to the subcortical small vessel occlusions. And those, they're still important, but again, they're not the STEMIs, so to speak. So this is a typical how a small vessel stroke looks. Everything inside this core right here is considered subcortical right there. And everything outside, outer rim, is the cortex, which is involved in larger vessel strokes. So this patient will, this is the right side of the brain, will have some left hemiplegia, cortical functions will be intact, so speech is for most part intact, vision is not affected. They may have some minor symptoms like, arm drift, may have some dysarthria or numbness, things like that. But the bigger ones where language content, they're speaking fine, but maybe a little bit slurred, their vision is good, gaze is normal, they're looking all around, tracking, no problems with that, and they have no neglect. They know their whole body, are able to work with rehab very well. So again, we talked about the hallmark of large vessel occlusion: weakness, gaze abnormality, visual field cut, aphasia, neglect. So how does a left MCA occlusion look, right? So when we look at the CT scan, that's where that left MCA should have looked like this. This is the occlusion. We see with the left comes right-sided symptoms. We have right-sided weakness, face and arm worse than the leg, aphasia, gaze maybe to the left, may not see things to the right. These are, again, same thing, 4 key stroke symptoms. So one of the kind of the tricks that I use to say, which side is the stroke or is this really a large vessel stroke is whenever there is large vessel occlusion, the patient is always looking to the side of the stroke, right? And that's how I immediately know that this is one large vessel occlusion and where exactly the clot is. So in this case, the occlusion is on the left side, left MCA, and the patient is looking to the left. And this is a trick we also use sometimes to differentiate some of these larger seizures versus stroke. So we may have some patients that have had, say, previous brain surgery for tumor removal, and they have seizure coming from scar tissue around that surgery. And if that seizure is coming from, say, for example, let's say in this example, left side of the brain itself. Tumor was here, meningioma, resected 10 years ago, has some scar tissue, has been struggling with seizures, now had a seizure. Because it's a focal seizure on the right side, they will still have right-sided, or focal seizure on the left side, they will still have right-sided symptoms. So now for you guys on the field, the question is, we don't know what really happened, no witness. Patient does have some right-sided symptoms and still behaving like stroke, is sleepy, cannot speak. But then the question becomes, which side is the gaze? In stroke, always the patient gazes to the side of the stroke. So if this patient were to have really a left-sided occlusion, patient would be looking to the left. If that same patient had seizure from a left-sided meningioma resection, patient is looking to the opposite side. So I think that is some of the, a trick that we use to differentiate between seizure versus an actual, stroke occlusion. That's how a right MCA occlusion looks. Again, just opposite of our previous case. In this case, patient is going to be gazing to the right. Right MCA occlusion, patient looking to the right, left-sided symptoms with arm, face, and leg weakness. So this is the atypical kind of the problem child, so to speak, where we say, this is basilar artery. So normally basilar artery would come up and divide into 2 PCAs, or posterior cerebral artery. That whole piece is missing there, and we see sudden unexplained loss of consciousness, altered awareness, requires high index of suspicion. So anything that is sudden. So what can cause sudden unexplained loss of consciousness? Very few things, right? It's either something devastating, large MI, and patient is now not perfused, but then you see low blood pressure. Is it a massive PE? Patient is not oxygenating. We see that on your, the pulse oximetry or Untitled monitoring. Third thing is basilar artery stroke, right? Very few things really cause sudden loss of consciousness. And definitely when we hear that it's sudden, patient was fine, went to the restroom, in next minute found on the floor, not responding, eyes are deviated, disconjugate, pinpoint pupils, but pressure seems to be high, oxygenating well. So you've ruled out that STEMI part, the cardiogenic shock, the PE, then think about basilar. This is the one that is very commonly missed in the ED as a mimic. We have had several patients, I think the second or third patient that I took to the lab after my fellowship training was a audiologist at in Binghamton where I also practice, and came in 47 years old, sudden loss of consciousness, husband couldn't wake her up, brought to the ED, no risk factors, nothing, and initially was seen and kind of diagnosed as psychogenic disorder, right? Malingering, where there's like, why is she not waking up? She's only 47, no risk factors. Then eventually, this is 10 hours later, still not waking up. They've done all the interventions, and then I get a call from actually the MRI tech saying, hey doc, we can't see the basilar artery, and we had to take her to the lab at hour 14. She's back to work now, but that's the thing. It's where a lot of times the posterior circulation is the problem child. They are the ones that are in that second 10%. Very vague symptoms, but they are stroke. We have the stroke mimics, which are, they are typical stroke symptoms, but end up being seizures or migraines. This is the other caveat, where odd symptoms, but they end up being real stroke. So always think about anything unusual, abnormal, if it doesn't make sense, but is causing neurological problems with sudden onset, think about posterior circulation. Never discount it. And this is a good way to kind of, a checklist to say, is this posterior circulation? And all of us have problem with this, from ER physician to stroke doctors to interventionalists. And I mean, now if I think it's a stroke and I cannot explain it, I say it's a posterior circulation stroke. And the commonest symptoms though are dizziness, diplopia, double vision, dysarthria with some motor speech disorder. Give me 1 second. And dystaxia, or just ataxia, what we call routinely lack of muscular coordination. So like you can see, none of these are unique to stroke. Dizziness can be from positional vertigo. Diplopia can be from several ophthalmological conditions. Dysarthria, yes, very common from stroke, but also could it be something else possible. Dysphagia, it could be very minor. Hey doc, I've been choking on things, or grandma couldn't swallow down her dinner, but everything else was fine, right? So very kind of a vague symptom. Ataxia, again, several things can cause ataxia. Just being 90, sometimes you can be ataxic and falling down. So very vague symptoms, but still could be posterior circulation stroke. So I think that's why I keep on repeating posterior circulation, be careful. And this is kind of the 4 common stroke scenarios that you guys see on the field. We have what we call the small vessel strokes. Majority of strokes end up being small vessel. We do have these hypovolemic strokes from cardiac reasons, septic reasons. Then the hemorrhagic stroke, about 13% of all strokes. Large vessel, about 30 to 40% of all strokes. Okay, and kind of this is understandable. So it all starts with the EMS. We know that, and that's why we are here to collaborate. And so most of our calls, right? I mean, you guys agree, majority of the time when it has that stroke flavor, it starts off as either a slurred speech, maybe weakness, unresponsive, worst headache of my life, subarachnoid, hemorrhages are usually that's how they present. And then, we have these common stroke severity scales. Different region develop their own, different kind of a stroke scale to assess. We have the Cincinnati pre-hospital stroke scale. We have the Los Angeles motor scale, the RACE, which is kind of more prevalent in the Southeast. We have the VAN, more prevalent in the Midwest, the FAST-ED, which I think nationally probably has the most exposure, and that, very much common along the East Coast and in the, some of the southern states, Georgia, things like that, where they've already adapted fast quite quickly. So what does the FAST-ED scale, actually mean? What does it entail, right? And this is, most of you guys know this, where we say, facial palsy, normal, and then there's a scoring, right? 0 to 9, and we have facial palsy, normal or minor, partial is a 1, arm weakness, drift, no drift or no effort against gravity, speech absent, mild to moderate, severe, how long since the patient was last seen well. Again, that doesn't score, but it's a very vital piece of information. These are the two new things that was added to essentially the FAST score. So eye deviation, we said, is it absent, partial eye deviation, forced deviation, and then we have denial or neglect, basically, which comes like we saw from the parietal lobes. Is it absent, extinction to simultaneous simulation in one sensory modality, and does not recognize own hand or orients only to one side of the body. I think this is a good time to do the like a quick demonstration of the FAST thing itself. Any questions about the actual scale? Any concerns about the scale? So that way we can focus on those aspects of the exam. No questions. Pretty confident about the scale itself, or yeah. So yeah, we won't spend much time on the first four. I mean, time is time. Speech, we all know, you guys have been using the FAST from before. Speech, we know, is there speech abnormality or not. The higher score for somebody who is completely aphasic or mute. Weakness, again, pretty self-explanatory. Facial palsy, self-explanatory. I think eye deviation and denial, neglect is where we are going to see. Now, with considering Jen, I think what we'll need to do is, Jen, can you recreate, like say, eye deviation or, yeah. So, say for example, now let's go back to normal, right? So, in a normal patient, we have no eye deviation. This is our, small vessel strokes where the eye is not involved. And I say, hey, Jen, can you follow my, finger or the pen torch? She's moving all around. So no gaze deviation. Can look up, down. Can you look towards Christy on your right? Yeah, can you look towards the whiteboard? She's able to see everything. So this is basically normal, where we said eye deviation is absent. So what would be a partial deviation? Now let's say patient has a left MCA, Jen has a left MCA stroke, so she's looking to what direction? Left side, right? So she's looking to the side of the stroke. So let's recreate a left MCA. So now Jen, at baseline, we are seeing on the field, she's looking to the left, and I say, Jen, can you follow my finger? So she can only track to maybe the midline, and then after that cannot track, right? But then, can she go all the way to the left? Yes, she can go all the way to the left, right there. Comes back again, slightly favoring the left side of her body, left side of her face, and cannot definitely go to the other side. So patient is looking to the side of the stroke, cannot cross the midline, cannot go to the other side. That is partial 1. Forced deviation. So right now we are seeing patient is like that, a little more, see, like that. You can relax that way. And then, so left MCA stroke, looking to the left side, right side is weak, hanging down, leg is rotated out, no tone in that, and probably even more, which is going to make Jen work hard. Yeah. So that is our typical eye deviation, forced deviation 2. Can everybody see? Yeah. So that's a forced deviation 2. So definite marked deviation. Sometimes when I bring such patients to the angio suite, to the cath lab, we have to actually basically forcefully turn the face over and put, you know, extra pillows on that side to orient the face, you know, in midline. So it's that significant of a gaze deviation. But that's how significant it will be. And this is where there is no chance that she's able to come to the midline nor even follow the fingers, nothing like that. It's full, complete face deviation. That's a 2. Now, Jen, we can, break time. Yeah. All right. Now, when we talk about the denial or neglect itself, so absent is, you know, completely normal sensation. This, I think, 1 and 2 is a little bit of a confusion. What this fancy terminology means: extinction to bilateral simultaneous stimulation in only one sensory modality. I'll give a little bit of a anatomical basis for that, so that way it's easier to understand. Now, when we talk about sensation, most sensation is spinal in nature, meaning vibration sense, hot and cold, pinprick, position sense. Those are all, you know, evaluated in the spine and the brainstem, right? So when there is a spinal injury, that's when we have, you know, numbness, we have that weakness, we can't feel where the legs are, or vibration sense is lost. The only sensation that is a cortical function is identifying simultaneous stimulation. So what does simultaneous stimulation mean to me is, say we have, so if with eyes closed, Jen, eyes closed, can you feel me touching?
Yes.
Yes. And which side?
Left.
Both, right? So, yeah, no. So that is normal, right? Where we say, what is a cortical sensory function versus a spinal sensory function? A spinal sensory function is vibration sense, pinprick, hot and cold, light touch, pressure. Those are all spinal sensations, very primitive sensation. The simultaneous stimulation, where the brain can fathom stimulation at 2 different points on the brain simultaneously, that's a cortical function. The goal of FAST-ED is to identify cortical dysfunction, right? So we want to assess a cortical function, which is simultaneous stimulation. So now let's say what we did right now, where Jen was able to feel touch on both the right and the left hand, is normal, and that is a 0 on the scale. Let's say how she's going to behave with the score of 1, where there's loss of bilateral simultaneous stimulation. So say, for example, we say, hey Jen, she has a left-sided stroke, left MCA stroke. The sensation on the right is most likely going to be affected. And we say, Jen, close your eyes, and can you feel me touching?
Yes.
Where do you feel me touching?
On the left.
On the left, right? So she has now sensory loss to that one side, specifically on that double simultaneous stimulation. When with the eyes open, if I say, hey Jen, do you feel me touching, pressure on the hand? No. Sometimes it may be a no, it may be yes, doc, you know, I feel some, but when we do it together, it extincts. Does it make sense? So the sensation is not completely normal on that affected side. It may be reduced, but when with eyes closed, both are stimulated, they don't feel it on that side. So that's the difference between just sensory loss versus sensory extinction. It's always to that dual stimuli. And the extreme kind of that is does not recognize own hand or orients only to one side of the body. And that, you know, the extreme findings you can easily, you know, identify relatively easily, where we say now the arm is kind of, this is our typical thing, arm is flopping on the side, and I say, hey Jen, whose hand is this?
I don't know.
You don't know. Yeah. So that's the typical answer, right? They don't identify that side, and that's the extreme kind where, and that usually also comes with extreme gaze deviation. So gaze is to the left, they're not recognizing this hand. I'm saying, hey Jane, can you lift your right hand? Can't move that right hand. Whose hand is this? They don't know. Sometimes they cannot speak. You and it's the extreme form. That is, I think, easier to identify, complete disregard to that arm or the side of the body. That one is where we have to say, how can we quickly, safely assess that? Very commonly, if the patient is able to interact, then we say, can we assess that double stimulation, double pinprick, or double pressure points, or double light touch? And if the patient is able to give us an answer, yes, no, then we score it. But the beauty of the score is that we don't need all of these points to get to a fast ED score that will tell us it's a large vessel occlusion, right? I mean, when we say, so this point here, score of more than 4 on fast ED scale can indicate LVO. So if the patient had a facial droop, significant arm weakness, 1 + 2, 3, and some eye deviation, 4, that's already indicative of a large vessel occlusion. You don't even need to be able to clearly identify this neglect or sensory issues. The reason I'm saying that is very frequently I get asked, hey doc, if they have speech difficulty 2, they have arm weakness 1, how am I going to assess the sensation accurately? So in those cases, I don't think we should spend too much time on trying to get that accurate score, or wasting time on trying to get the exam over and over and over. To say, okay, let's go down the path. Mild left facial droop, arm is not moving, 1 + 2, 3, speech is impaired or globally mute, 3 + 2, 5, fast TDRD 5, large vessel occlusion, let's start the process, right? And the extra other scores obviously will be beneficial. We want to score the entire score, but if this is not retrievable because of speech issues, then we do say, let's keep moving. Any questions so far about the exam itself or anything?
With the paralysis, it would
Yeah.
be the whole side?
If
If it was in the hand and the arm, it would be that whole side always away?
Most often, yeah. Most often with stroke, we do see that, the whole body on that side, like hemiparesis, right? That's usually our typical presentation. Most often the arm, yeah. Most often the arm is affected more than the leg, yeah. And it can also involve just isolated. I think that's what Christy was alluding to, was it doesn't have to be the fact that just the arm is involved and not leg doesn't mean it's a less severe stroke. If just the arm could be involved, or just the leg could be involved, sometimes it's the whole body. But irrespective, we need to still score it the way it is. And since the arm is most often affected, very rarely that the leg gets affected individually with the arm being normal. That's why arm weakness sits on the score rather than anything else.
So the leg being affected and not the arm would be most likely something different?
It is still a stroke, just the territory is different. And let me see if I have a different slide for that. So we're going to that's a very good question. No, here, yeah. So if the question was, if just the leg is affected, not the arm, is it something else other than the stroke? So it is the answer is no, it's still definitely stroke. It's just different vascular territory. And just a quick deviation coming back to our vascular anatomy. We said MCA is the most common site for the occlusion, followed by ICA, right? And then basilar artery. Least common location is the ACA, anterior cerebral artery. The reason I kind of restating this is because the blood vessel that supplies the leg control in the brain is ACA. Right? So when we said MCA is about 55-60% of the stroke, internal carotid is another 15 to 20, basilar is about 10 to 12, we see that the small minority is ACA strokes. I haven't retrieved a clot in ACA probably in the last 18 months. The last 5 clot retrievals for me were MCA. So when ACA is so infrequently affected, ACA supplies the part of the brain that controls the leg, which means the leg is very infrequently affected. But when we see leg weakness more than arm, then you're thinking ACA stroke. It's still a stroke, but not your typical MCA, ICA stroke, but the ACA stroke. And where we see full body involvement, but arm more affected than the leg, that's your ICA. Because if ICA is blocked here, there is no MCA nor ACA, so arm and leg are going to be affected. Just because arm has larger representation because of our thumb, which is the most complex finger in the body. When the MCA is affected, larger part of the arm is affected and arm becomes weaker faster. Yeah. Okay, oof, a lot of slides. Okay. So everybody's comfortable with the FAST ED scale, right? I mean, any questions so far? Any concerns? Good to go? Yeah. So when we talk about the Jen, I think we should be good, unless you like the stretcher. Yeah. Go ahead, please.
Before, when we brought them in, you asked to see if they could move their hand past midline, and they stop right at the midline. What exactly are you determining with that?
Correct.
As you ask them to move.
Yeah, very good question. Yeah, so I think if somebody didn't hear in the back, is when previously we were asking patients to see if they could move their arm past the midline, what were we assessing before? Is the same thing. The neglect part is when they have, that's the extreme part of neglect. When we said, the number 2 on the score.
That would be down around 2.
Exactly.
They can't move past,
Correct.
That's 2.
Because what's happening is now when they don't know the right side of the body exists in their brain, they don't know what midline is, right? Because when you know midline, because you have equal understanding or perception of left to right. If your whole brain is thinking only left exists, your midline is somewhere here. When you know left and right exist, the midline is here, right? So when they couldn't move past the midline, that would tell us that the whole right body is now not represented in the brain, which means left parietal stroke. See, that is a little harder because it's either 0 miles or 100 miles an hour, right? There's no in between. So then if now patients can maybe move, but they are weak, cannot move, do we score that, not score it, things like that. So it's a little dependent on multiple different factors before we get to that score. And it's a very binary score, 0 or 100. In this case, we have a little bit, a little graduated scale. It's a 0, 1, 2, and it's not dependent on if the patient can move or not. And most often, the side that's affected is also weak. So I think those were the challenges with the previous assessment. So different stroke types require different treatment. We talked about the small vessel strokes. Still, majority of the strokes that we see are small vessel. Definitely a good candidate for those TPA kind of interventions. The hemorrhagic strokes, which are, we talked about hypertensive, subarachnoid hemorrhages, large vessel strokes. Those are the ones that require advanced imaging to localize the site of the clot. TPA generally not effective in breaking the clot and require many times combination of TPA and intervention. Sometimes they're outside TPA window, require intervention only. So this is not new to this group. We won't spend too much time, but not ready to treat stroke, stroke ready, primary stroke, comprehensive stroke. This may change in the next 2 or 3 years with New York State Department of Health, but we get the idea. And why does hospital choice matter? Again, there is a high chance of losing time by going to a hospital not equipped to treat stroke, right? This is something that you guys know better than anybody else. And frequently the time lost is roughly 12 hours or more between intake, registration, triage, getting the scans. Sometimes in the hospitals that are not ready to read or treat strokes, they don't have radiologists to read the scans. They go out to Nighthawk Radiology. The reports have to come back. The ER doc has to then see it, then initiate the transfer process. In our side of the country, weather is again a problem. The transfer may not be fast. Sometimes med flights are not available. So because of all of those reasons, we all know it's a no-brainer that going to the wrong hospital is a lot of time delay. Sometimes there is family hospital preference. Right now in New York State, I think we don't have a clear designation like STEMI PCI for stroke. There's a lot of talk about creating some of those guidelines, creating some of those diversion guidelines, so to speak. But right now, I think this is where our EMS folks, you guys will be very much valuable in kind of educating the family, the patient sometimes in what is best for them, right? In advocating what is best for them, in saying, hey, family may have a preference. Many times it's for the right reason. Hey doc, we went to hospital X because our primary care physician was there. We went there because it's closer to home, because that's where all our family has received care, things like that. But in many times it may not be the best choice for the patient, where advocating for the right institution, right place, right time, I think on the field is very, very important. So we have some case scenarios, kind of integrating all of these, the fast ED, the treatment parts, everything into the thing. I kind of want this to be interactive. So, basically case one, Mrs. Jones, we have 9-10 hours EMS call to local coffee shop when Mrs. Jones began to experience symptoms of garbled speech, dropped her coffee cup from her weak right hand. She's 68, hypertension, current smoker, very, very common scenario. EMS is at the scene at 9:20, patient alert, distress protecting airway, some slurred speech. I think this is something we need to focus on. Slurred speech, little movement, right arm, mild right facial droop. So what would the fast ED score be on this patient if we have to come up with a score? Three, yeah. So between 3 and 4, right? Yeah. I mean, there is 3 things that are listed here. There is slurred speech, little movement that is indicative of a drift. It's not completely weak, not that 2 that we would score. Still has some movement, drifting, maybe dropping down in a few seconds. Mild facial droop, we said partial facial droop. So that's a 1, 1, 1. 3 is the most, probably the score that I would give. Blood pressure is elevated. So we check the vital signs, all the routine stuff. Fast ED score taken, we said 3 score. So our magic number is 4 and over, right? So 4 and over is large vessel occlusion. This is a 3, less likely that this is a large vessel occlusion. And here we go. What is your field diagnosis? Obviously stroke. Again, when we think about, same like in chest pain, when we talk about chest pain, automatically we are now so used to thinking about chest pain as, hey, let's make sure is this STEMI or non-STEMI group and everything else. So same way in this case for stroke, what I want you guys to kind of train yourself to think is, what is your field diagnosis? Stroke. So then what kind of stroke? Is this large vessel or small vessel? The answer is small vessel, right? So then we said small vessel. What is the appropriate disposition for this patient? Which type of hospital should Mrs. Jones be brought into? What would be the answer? Yeah, so definitely still stroke center. Again, we say, hey, fast ED score is 3, coming to the stroke center. And then we'll talk about how that fast ED score on the other side of the fence, when we hear it, ER hears it, and if I hear it in the middle of the day, how I respond to those scores and what it means for us on the hospital side of things. We're definitely going to talk about that in a little bit. But again, so patch call to the hospital, loaded to the rig, triage is expedited, and stroke team alerted. 45 minutes from onset, CT scan reveals old lacunar infarct, nothing acute, right? So that's that old lacunar infarct. Again, we said we want to see a normal CT on all our strokes. That's our goal. If we can see normal CT, that's within window, that is something salvageable. So in reviewing this case, so this we already said, was this a large vessel, small vessel? It clinically sounds like a small vessel stroke. Was it appropriate to bring this patient to the stroke-ready hospital? Absolutely yes. So that was a pretty straightforward case. A lot of our stroke cases are like this, the smaller vessel strokes. Case 2, Mr. Smith, 90-year-old, hypertension on multiple diuretic medications, antihypertensives, is a nursing home resident and found by nursing home staff unresponsive in his chair, in his room. Very common scenario. Last seen normal 11:30 when maybe medications were being administered or just before lunchtime, and EMS arrival in 15 minutes, 13:30 hours. We said at the scene, patient awake but hemiparetic on the left side. This is just similar to what kind of what Jen was recreating. Hemiparetic on the left side, vital signs, heart rate 110 tachycardic, blood pressure 75/50, blood glucose, appears to have a dry mouth, fast ED score calculated, and last normal seen 11:30. Anything unusual in the information that we have? BP, right? So definitely one, it is low even from a normal standard. When I was going through training, one of the key things I was taught is if the blood pressure is not elevated, you have to be very bold to say it's a stroke. So brain, being the captain of the ship, always drives the blood pressure high if it's not seeing blood, if it's hungry, right? It's going to do everything it can to bring that blood pressure up. So when we say this is a stroke and blood pressure is 75/50, it's either one of two things. We are, one, knocking on the wrong door, it's not stroke, or there is something else going on with stroke. And what could this scenario be? Is stroke with maybe aspiration and pneumonia sepsis, right? Possible. Is this MI, atrial fibrillation, and then stroke with cardiogenic shock? Possible, right? So those are the things. So essentially when I see this, we're not saying it is not stroke, we are just forced to think, is this stroke with something else? When I see a low blood pressure with stroke-like symptoms, definitely say there is something else going on. Yes, this patient needs that stroke triage, but also what else? So let's see how this patient develops. So we said fast ED score pretty high, facial palsy 1, arm weakness, significant weakness, had speech changes, could not speak. There was no eye deviation, no discernible neglect, score still 5. So this is now a suspicion for, we said stroke, small vessel, large vessel, this is large vessel, but then also now we have a supplemental diagnosis running side by side, which is what is causing that low blood pressure. So what's the decision making here? Fast ED score 4 or higher constitutes stroke call, patch call, high likelihood of large vessel stroke. Decide to take this patient to a comprehensive stroke center, patient loaded, absolutely like you guys recognize, low BP is sticking out, start IV line, bolus, and BP is now up, arrival to the comprehensive stroke center. And then what does the CAT scan show? This is again not an uncommon scenario where we said we want a normal CT scan. In this case, it's not normal. We have hypotension, hypodensity all around the right MCA territory, right? So this is already kind of, we missed the bus. It's already done. Stroke is already formed, nothing that we can reverse. CT scan reveal large area of brain involvement. This is all the dark colored hypodense region is all the evolving established stroke. And then urgent CT angiogram. Usually when there is higher fast ED scores, we already prepare for the CT angiograms. That is part of the things that helps us predict and prepare. And CT angiogram did not reveal any large vessel occlusion, just diffuse atherosclerotic disease consistent with his age. And what kind of stroke was this? It was a small vessel hypotensive stroke, right? This could have been because of sepsis. Was it because of dehydration? That's what it looks like in this case. Is it because of cardiac compromise, cardiac failure, cardiogenic shock, and diseased vessel? So you have low blood flow going through already narrowed blood vessels, resulting in larger stroke. So that's what this was. Do you triage the patient to the right facility? Absolutely, to stroke center, because fast TD score was 5. IV fluids, that was the right choice. We picked that up. Always, blood pressure, blood pressure, blood pressure. If it is high, leave it high. Brain needs the perfusion. If it is low, think of a second diagnosis. And then time to CT approximately 3 hours. Patient did not do well, large stroke, 90 years old, so it's going to be a bad outcome. We have case 3 now, Mrs. Green, 82, female, hypertension, calls from the bingo parlor, developed a, stay away from the bingo parlor, that's my diagnosis. Huh? So she apparently developed acute headache, loss of vision, left side began 4:10. So patient is moderately distressed, pain seems to be worse, blood pressure 200 over 120, finger stick okay. Now we have this difficulty moving right arm, leg, visual loss, eyes seem deviated to left, mild difficulty understanding your commands. So what's the fast TD score on this? So about, I'm hearing 6, 5, 5, 6, and I think that's what I would give that patient to. If in doubt, what I always do is score the higher score. You rather triage the patient towards treatment than deny the treatment. So if you're in doubt 5, 6, go with 6. What is also abnormal in this or atypical in this presentation? What's that?
She's got difficulty moving the right arm, loss of vision on the right side, but deviating a lot.
So that is still consistent, right? So if we said, say for example, I mean that's a good review point, right? So if we said right arm, leg weakness, we are saying left MCA, left ICA territory. So patient will look to the side of the stroke. So she is looking to the left. So that is correct, yeah. Seizure is to the opposite side. Stroke is to the side of the stroke. So in this case, patient is looking to the side of the stroke. What else kind of is a little unusual in this typical stroke presentation? 150 is, I think, yeah.
Monitor showing sinus rhythm with the blood pressure that high.
Pain, right? So normally, if it's a typical ischemic stroke, there's not pain, right? When we say, all right, all these stroke symptoms, patient is 80 years old, she has pain, headache, what are we thinking? Hemorrhagic, right? Absolutely right. So I think that's something that we need. Typical ischemic stroke causes loss of function. It doesn't create pain. It takes away sensation, in fact. So when you see pain, it's one of two things. If it's a patient, in my mind, that the way I kind of mentally triage it is stroke symptoms with pain, less than 50 years of age, think of dissection, right? Because that's when carotid dissections, vertebral dissections are common. They're going to the chiropractor or back from a game of football, some kind of moving heavy objects, things like that. Dissection, stroke with pain, less than 50 years of age, think of dissection. Stroke symptoms with pain more than 50, think of hemorrhagic. Right? So that's the one thing that kind of sticks out from usual typical stroke presentation. Stroke fast TD scale 5, 6 is not wrong. So what's the decision here? Again, fast TD score more than 4. We are bringing this patient right away to the comprehensive stroke center. So was brought over at 16:55. EKG is normal. IV fluids was not given because of continued hypertension. Some morphine for the headache itself. Obviously, large bleeding right there, which goes with the pain and everything else. So I think on the field, this is a good example. Impossible to say is this ischemic versus hemorrhagic. I think there are some features that will say now if this patient did not have pain, do we say this was absolutely an ischemic stroke? Cannot tell. But pain is a good indicator that it possibly is hemorrhagic. And the other good point that you guys raised was this blood pressure. We do see elevated blood pressure, but 200s most commonly is hemorrhagic. Typically ischemic, we see high 160s, 170s, 180s. I think that 180 range is probably our most common ischemic range. Again, it doesn't mean if somebody is 180, they don't have hemorrhagic, but this is usually the trend. Very high blood pressures, think of hemorrhage. Pain, think of hemorrhage or dissection. So anyway, so angiogram performed revealing bleeding vessel in the left posterior circulation. Looks like a subarachnoid hemorrhage from a ruptured aneurysm. This is what we do, using coil embolization. What kind of stroke was this? We already said this, hemorrhagic stroke, triaged, absolutely correct. Again, come to the comprehensive stroke center, fast ED more than 4. Could you have done anything else? Triage at the stroke center, received CT, everything according to the standards, and then eventually, went on to get treated for the bleed itself. So then we have case number 4, 62-year-old farmer, occasional smoker, mild hypertension, dyslipidemia. Last seen normal when he headed out to the fields after dinner, was mowing fields when he developed acute aphasia, weakness of right side. Right hemiparesis, acute aphasia, was able to somehow drive the tractor back. Wife calls the EMS. EMS is on the field. Where is this? Okay. So EMS is on the field in 10 minutes. Patient is aphasic, hemiparetic, but no eye deviation. Last seen normal 60 minutes prior to your arrival. So IV started, no fluids, BP is normal. If in doubt, I always say give fluids. Everything else is okay. Fast TD score, just in the interest of time, we're going to skip to the actual things. So patient had some facial palsy 1, arm was definitely weak, could not move that arm. 2, speech, was not able to speak. There's no eye deviation, no neglect, still fast TD score 5, right? So we are already saying, yes, this is a stroke, small vessel or large vessel. Fast TD score of 5, it is a large vessel, needs to come to a comprehensive center. And this is one of those dilemma, not necessarily in Utica region itself, but North Country. I think we do have some of these challenges where we say, hey, the closest comprehensive center is either St. Luke's or it's Vermont or Montreal, Albany, things like that. What do we do then? Comprehensive stroke center 120 miles away, stroke ready hospital 20 minutes away. So your decision is obviously then becomes limited by some of the geographical factors. So right now we still say, bring to the local community hospital. And what happened here? This is our typical spoke hub model, so to speak. So CT scan performed within the first 15 minutes is normal, no bleed. That's what we want to see, normal CT scan. ER physician makes an assessment, stroke scale 18, goes in line with that high fast TD score, right? Large vessel occlusion, large NIH stroke scale. And then TPA is given, patient was within the window, and this community hospital is a spoke to a larger hub. So the center, comprehensive center was 120 miles away, comes over, smaller hospital, refers to the hub hospital, calls the larger center administering TPA, makes the referral cases accepted, med-flight arrives at the larger center. And then what do we see on the angiogram? This is that left MCA occlusion, complete occlusion here. This is the internal carotid artery going up. This is the anterior carotid. That is the anterior cerebral. That's the middle cerebral, completely occluded there. Very common scenario. About half to 60% of all my strokes, I see that on the angiogram. So at the comprehensive center, CD shows large left MCA occlusion. Time is still relatively early, 4 hours, 20 minutes. TPA is given. Did not obviously open up the big vessel, and eventually patient went to the cath lab, got the standard of care, and then reperfused. Now, when we look at the large vessel occlusion, so this is kind of our main focus patient today. When we look at those large vessel occlusions, 5 times higher mortality, 3-fold reduction in good outcome, right? And when we say, there's a math which I don't recall exactly now, but every kind of 15-minute delay or extra stroke damage takes away almost 1 day of their lifetime. So I think that's where we want to say, especially in these large vessel occlusions, where we want to say time is of the essence, and then opening up the blood vessel is the second most important thing. Responds poorly to IV TPA, and if you think about it, in a very kind of a basic physics perspective, if the clot is in the left carotid artery, say for example there, the blood has to flow through the carotid and get to the clot, and the blood carries the TPA. If the carotid is occluded, the whole blood flow coming back is now occluded. When we give TPA via the IV lines, it's going to go through the path of least resistance, which is every other vessel than the occluded vessel, right? I mean, it's very basic physics. Very little of what we give IV is going to reach this clot. There's the clot, complete backlog. TPA coming out of the heart is going to go carotid, vertebral, basilar, all of this except this. So we know the larger the clot, lesser the flow to the clot, meaning less TPA. So those are the ones that we need to say, hey, the TPA is not going, still the standard of care, we still start the process, we still do the drip and ship. We drip the patient, that is working. Whatever little effect it has, still has started from time 0. We then go in, disrupt the clot, bring the clot out. This is where Drano has stopped working. We need the roto-rooter, right? So that's basically what it is. So this is the device that we use, most commonly used. Mark from Stryker, they were generous to bring us dinner. They have the flow model. I think he also has the device demo that you guys can see, feel, and see how it kind of reacts. But that's essentially the stent retriever, an actual clot, and I think there's a demo video itself that shows how this stent retriever works. So that's a microwire that we pass across the clot. Then that's the catheter that goes, kind of buries into the clot, goes into the clot itself. That's the stent retriever coming out, and then that's under the X-ray vision. So over time, I usually wait for about 2 or 3 minutes for that whole stent to open up inside the clot, kind of engage the clot, so to speak, and yeah. So if you notice here, we have this is our catheter through which we deliver all the devices, but that also has a balloon. So a balloon guide catheter. The reason we have a balloon is So one of the commonest questions I get asked is, hey doc, when you're removing the clot, what if a part of it escapes and goes someplace else? And that's why we have this balloon proximally in the neck, is just before that retrieval pulling part, we inflate the balloon for about 30 to 45 seconds, creates flow arrest. So when there's no forward flow, there's no chance of clot escaping out, right? So there is one, just the design of the stent catches the clot quite well. There is antegrade flow arrest, no blood flow going up, which means no clots floating forward. And the third safety factor is we have this guide catheter hooked up to a suction. It's like a fancy Dyson that's many $1,000s, but that suction essentially pulls blood backwards, right? So then say the stent retriever is coming out, it's going through all these turns, small clot escape, at least it's not getting pushed because balloon is inflated. How do we get that back? Because of suction. So all these three factors cleans out the pipe pretty well.
Keeps the blood flow coming from the other side.
So that's a good question, and that's why the suction helps. So even if, say, there is like an anterior communicating artery that's, even if it comes, say, from the other side, it's going to go across and get all sucked out here, right? So that's why we, and it's a very, very good question, and because initially we started just with flow arrest. The first device was just the device. And then we said, hey, this embolization to new territory is almost 15% with the old device. This I'm talking 1999, 2000. And then we said, let's do the flow arrest. That dropped to 8% embolization to new territory, right? And then we said, let's also add suction, proximal suction. So those things, blood coming from the other side, now again got sucked back here. Now embolization to new territory is less than 3%. So barely any, dislodgement of the clot. So what kind of stroke was this? This is our typical ELVO or emergent large vessel occlusion. Triage definitely needs to come to the comprehensive center. And this was a good example of how the hub and spoke model works, and this is very important for our community. In this region, upstate region, North Country, where we have the smaller hospitals, they definitely need to start the IVTPA, but not stop at IVTPA in saying, hey, IVTPA is done, fast ED is still 5, where do we get them next? Because occluded blood vessel is not going to get enough of the TPA. When we look at, I don't have a slide in this presentation, but when we look at the statistics, with ICA occlusions, the chance of recanalization is less than 10%. So if we don't know where the clot is until we do the imaging and things like that. We may not know that answer when we give TPA, because TPA is given just based on plain CT scan. So if there's no bleeding, patient within 4.5 hours, they get TPA. But if it's a large vessel occlusion, like an ICA clot, MCA clot, the chance of recanalization less than 10%. So they definitely need to come to a bigger center to get that clot recanalized. Okay, so all of that. So this is just some of the basic conclusions. I think we are probably to the last slide, thank God. So anyway, 4 basic patterns of stroke: small vessel, hypovolemic, hemorrhagic, large vessel, and no radical change in the first 3. This is the one where a lot of change, a lot of practice changes happen in how we identify triage, where do we bring them. We talked about the fast ED score. Any questions, feel free to ask me those questions. We know about time is brain. 1.9 million cells die with every minute of ischemia. And basically the take-home messages, right? Make the transportation decisions accordingly. We are guided by what is the standard of care, what is best for the patient, and what does the guidelines say. So I think it's a tough decision on the field sometimes. but again, it I guess comes with some experience, and we are trying to make those guidelines as easy as possible from New York State to have it very black and white. Lytic treatment may be given up to 4.5 hours. Endovascular therapy, this slide is a little out of date. It says 8 hours, but we have now new trials that extend the time window up to 24 hours. So anyway, here it says time window may increase soon. That already happened. February of this year, we had 2 trials that came out, and we already know from the AHA, ASA guidelines where they have extended that time window to up to 24 hours for endovascular therapy. Don't waste patients' time, brain. That is again, very basic. We all know that, and different therapies are available for different strokes. And the simple lytic therapy, which is TPA, is effective for smaller strokes. However, endovascular is going to become the standard for some of the larger strokes when just IV TPA is not enough. Yeah, I think all done. Any questions?
You talk about the incidence of TIAs and the significance of TIA developing a real stroke.
So, the TIA is kind of one precursor before the small vessel stroke, right? This is kind of like the angina before the non-STEMI or before that acute coronary syndrome, so to speak. And definitely, I think that's where all of our preventive care has to be, is in identifying those TIA patients and saying, hey, these are the ones that need the treatment. And a lot of times, that's the reason we admit those patients. Even TIA, by the time they're in the ED, they're already back to normal. The stroke scales are 0 or barely 1, and we still admit those patients just because of that preventative value that they have in us being able to say several patients each week that we say who we admit with TIA end up newly diagnosed with atrial fibrillation, placed on anticoagulation before discharge, things like that. So again, going back to Vinny's question about what is the chance of having a vascular event in the first 90 days, that's about 12% of having any kind of vascular event, including stroke, MI, or some kind of acute peripheral vascular disease. So these are kind of the sickest vascular patients. So if there's TIA, we definitely want to see them, admit them, at least work basic workup, observe for maybe 24 hours, basic workup, make sure no AFib, no carotid narrowing, no intracranial narrowing, and then get them on the right medications and get them there. I think the eventual big picture should be TIA management, prevention at the TIA level. But I think until we get that education to the community, we get people to change their behavior, which is not easy. This is where we say, hey, the larger ones, let's be careful and get them.
We can be very, very beneficial by being good detectives, and we get to the hospital and say, I'm telling you, there was right-sided weakness before.
Correct.
But also educating the patient, because a lot of patients say, I'm all better now, leave me alone.
Exactly.
So
Yeah.
educating them, talking to 12% of people are going to have a full-blown stroke if you don't get it.
Correct. Yeah, and sometimes when I use that example, I have the same thing in the office. I see them in the hospital, and then they don't want to come back to the office for follow-up. They're like, hey, I don't know why he wants me to come back. I'm completely fine now. But that's where the prevention starts, right? And same way in a more acute fashion is on the field, where we say symptoms have gone away. It was very minor, maybe just some slight slurring, maybe vision loss for 30 seconds. I can tell you in the last year, probably 5 to 6 patients, vision loss, 30 seconds, 45 seconds, brought to the hospital, 90% carotid occluded, and I've stented them. So, I remember there's one local area, maple farmer, bouncing from primary care to ophthalmology to urgent care to then ED, finally lands in our ED at 6:30, and then 7:45 I put the stent in the evening, like 98% occluded. But that was same thing, vision loss for less than 30 seconds, right? So that's where I think, very good point that you raised, Vinny, is in that way is to say, hey, we need to be the advocates for the patient. even if they're refusing because of lack of knowledge. But I think that's where we need to kick in and say, definitely needs evaluation, even if it's for 24 hours. Yeah. Good. Yeah.
Does the vision return after you remove the clot?
Many times it does. The usual counseling that I give patients is the most complex function goes away first, comes back last. Right. So, because of how so many neurons involved, higher chance that something is affected, and if we have to kind of quantify the most complex functions of the brain, vision is probably the most complex. Speech is up there. Memory is also in the top 3 or top 4, and then movement of the thumb is also quite complex. We are the only basically living animal that has a thumb. So those are probably the 4 most complex. They go away first, recover the last. So if there were to be less recovery, that will be in these 4 aspects: vision, speech, use of the thumb itself. Those are the things, and memory problems. Those are the things that will probably less likely recover with the larger strokes. Now again, every person is different, but these are the 4 that kind of usually tend to have some lasting deficits. Yeah. There was a question from the back.
Compared to the other stroke scales, how does this, as far as superiority,
Mm-hmm.
Why are we
Choosing this versus the lambs and race and everything else? So there is really no, I think, clear superiority. That was the exact question that the community asked at the International Stroke Conference this year. Is there any preference over which scale is better than the other, or is there any advantage to one scale over the other? And the reason the American Stroke Association does not endorse one particular scale is for that very same reason. Is as of today, we don't have that data to say one is either statistically superior or advantageous on the field. The reason regionally, I think we have all adapted FAST-TD. That was something that New York State kind of adapted of all the stroke scales. So we rather start off with something that's going to be the future rather than retrain in 2 years. Yeah. Any other questions? Good? Yeah.
Here's your opportunity, take advantage.
Yeah.
No questions?
For somebody that's having a hemorrhagic stroke,
Yeah.
are they going to be prone to vomiting?
Absolutely, yes. So in the nausea, feeling of throwing up comes from increased intracranial pressure, right? So if we see in that same case 2 scenario or case 3 scenario that we had with hemorrhagic stroke, high BP, headache, also throwing up, we know that yes, this is most likely hemorrhagic, a most likely larger stroke, and probably is already causing some compromised early herniation. So those are the ones that we need to definitely bring faster to the ED. The only other caveat to that is stroke symptoms with nausea. Think about basilar stroke. And again, we want to bring them faster because untreated, 90% mortality. Right? So, what's that?
Do you want us to treat the nausea?
I think it doesn't change the outcome from a hemorrhagic or an ischemic perspective. It helps with aspiration. So the answer is yes. Yeah. Yeah. So Vinny, just the kind of the continuation to that is, if I get a stroke patient who I take to the lab, almost always I give them 8 milligrams of Zofran, because they're not our typical NPO for 12 hours kind of patient, right? So, and with stroke, especially basilar stroke, things like that, they are going to be nauseous. Fentanyl, Versed, they are going to be nauseous. So almost always fentanyl, Versed, 8 milligrams of Zofran, and then do that. I think from an outcome perspective, no direct stroke impact, but from a wholesome perspective, you do want to give some, anti-emetic, whichever, yeah.
Is there a preference, morphine or fentanyl for pain
I only use fentanyl. Yeah, definitely. If you ask me, I would say my preference is fentanyl. In some ways, I think better tolerated. In some ways, has no effect on intracranial pressures. Fast on, fast off. So doesn't change the stroke scales or the neurological examination after. Over time, Lisa is here from our interventional team. She will tell you our use of even Versed and fentanyl in the angio suite has probably gone down 50 to 70%. The last 3 cases, I can tell you, I did not use any sedation. Patient was relatively cooperative. We restrained the arm and the leg that was moving, and just good femoral nerve block, and the whole procedure is without sedation, just to keep that neuro exam intact. So if somebody is morphine, and now sleepy, I don't know if that sleepiness is morphine, hemorrhagic conversion, or worsening of stroke. So I want something rather fast on, fast off. It's okay to give 3 times rather than something that's maybe longer acting and I don't know what's going on. Yeah, so I've very minimal sedation use now in the cath lab for us. So is fentanyl available on? Yeah, okay. I would prefer fentanyl, I think. Yeah. What's that?
Just more paperwork.
Yeah.
Thank you.
Any other questions? Yeah, go ahead. Go ahead, buddy.
You
Yeah.
said with the hemorrhagic, there's a possibility for them to have headaches because of the intracranial pressure, correct?
Yes, intracranial pressure and also meningeal irritation.
So if you were to go in and you were to remove that blockage, would they almost instantly feel like pain relief, or would that still take time to subside?
So usually we do see, say for example, hemorrhagic stroke. Less commonly, that they are in the cath lab, right? Because more of hemorrhage, they're going for typical decompression, evacuation, craniectomy, that kind of a situation. But say, for example, this was a dissection and there was injury to the blood vessel that threw a clot, now a stroke. So normally in those situations, we remove the clot and then stent the dissection. In those cases, the pain relief is almost instantaneous. Yeah, pretty much, yeah. So a lot of times I don't have, I have a tech that works with me in the lab, and like he was, his observation exactly same as you. As soon as that patient becomes less agitated, we know that the clot is out almost instantaneously. So, we call it Fred sign now, in a thing. So, we're like, oh yeah, we have the Fred sign, because now patient is not pulling, yanking, things like that. No pain, blood is restored, brain is now normal, it's back to normal. And then the next time we do the injection, blood vessel is open, yeah. Okay.